Hello everyone and welcome to my YouTube channel. So this is the third part of ischemic heart disease videos. The first one is an overview and the second one is a stable angina, and it's present on my YouTube channel. You can check there. And the third part, which is going to be acute coronary syndrome, is going to be the topic of today's discussion. So let's get started. Acute coronary syndrome is a term used to describe the combination of unstable angina, non-ST elevation MI, or ST elevation MI. So these three terms can combine and they can be called as acute coronary syndrome, and it is due to rupture of coronary atheromatous plaque with superimposed thrombus formation. And all these components are part of ACS because their initial presentation and early management are similar. So this is a cross-sectional view of left anterior descending artery. The above one is normal, which is having a normal blood flow. The second one, which is having an abnormal blood flow due to ruptured plaque, but there is no superimposed thrombus. And these can occur in NSTEMI and unstable angina. So whenever there is a plaque buildup which is ruptured but it has no superimposed thrombus and it is not occluding the vessel completely, then it will result in unstable angina and NSTEMI. However, if the ruptured plaque starts to produce a thrombus by platelet aggregation and it will occlude the vessel completely, then it will lead to STEMI, which is ST elevation MI. So what is unstable angina? It is defined as a new onset angina or rapidly worsening angina which occurs at rest also, and it is not associated with myocardial damage, so the cardiac enzymes may not be raised. The ECG will show ST depression plus minus T wave inversion as in stable angina. Non-ST elevation MI is defined as localized area of myocardial necrosis, and because there is necrosis, so there will be elevation of cardiac enzyme but without ST elevation. So this will show ST depression as well as T wave. So the ST elevation MI is localized area of myocardial necrosis that will result in elevated cardiac enzyme, and it is due to complete blockage of the vessel. And the ECG will show any of the following. Either it will show ST segment elevation of more than or equal to 1 millimeter into contagious limb leads, or it can show ST segment elevation of more than or equal to 2 millimeter into contagious chest leads, or it can show a new left bundle branch block. So the clinical features include chest pain, which is the cardinal symptom, and it is retrosternal and radiating to jaw, neck and arms. The chest pain may be associated with breathlessness, vomiting, collapse, lightheadedness, diaphoresis, etc. The chest pain is more severe and lasts longer than angina, so it's going to be more than 30 minutes of chest pain. The chest pain is often described as tightness, heaviness and constricting pain in the chest. The signs may include signs of heart failure like raised JVP, crackles in the lung fields because of the accumulation of fluids, and S3 heart sound can be heard. Signs of ischemia like S4 heart sound, new mitral regurgitation, murmur can be heard, but these are not essential. So unlike a stable angina, the chest pain is not going to be relieved by rest or nitroglycerin. Some ACS can also show atypical features like dyspnea without chest pain, unusual location of pain, apprehension and nervousness, sudden mania or psychosis, syncope, severe body weakness, indigestion symptoms like nausea, vomiting, and even nothing else. So these can be atypical features. The most common cause of death within the first hour of ACS is arrhythmia, either VFib or VTAC, and after first few hours, heart failure. So basically, if I want to summarize the previous slides, so I can say that in unstable angina and NSTEMI there will be subtotal occlusion with thrombus, and in STEMI there will be total occlusion of the vessel. The history in unstable angina and NSTEMI will be angina is going to be new onset or angina occurring at rest. However, in STEMI, angina occurs at rest of more than 30 minutes. ECG of unstable angina and NSTEMI will show ST depression and T wave inversion. However, ST elevation MI will show ST elevation. Cardiac enzymes will be negative in case of unstable angina. It can be positive in case of NSTEMI because of the necrosis, and it's going to be positive in STEMI because of the necrosis. There is skip class, which is the categorization of the severity of heart failure. So the class 1, there is no heart failure and the 6% mortality rate. In class 2, crackles audible halfway up to the chest because of fluid, or S3 sound, and it has 17% mortality. In class 3, the crackles are audible in all the lung fields and it has 30 to 40% mortality. The class 4 includes cardiogenic shock with 60 to 80% mortality. So the best initial test and central to confirming the diagnosis is going to be an ECG, and it should ideally be done within 10 minutes of presentation. A single normal ECG does not exclude ACS, therefore serial ECGs should be obtained every 15 to 30 minutes. So the ECG changes that we can see include peaked T waves, which occur very early and can be missed. ST segment deviations, either elevation or depression, these are the earliest changes that is most commonly detected. So the ST segment elevation indicates transmural injury, that is throughout the thickness of heart wall, and ST segment depression, which indicates only subendocardial injury. Q waves can also be seen, which indicates prior infarction. T wave inversion can also be seen. So in this slide I have summarized the arteries which are involved in different type of MI and the leads on which you can see the changes. So from the blockage of right coronary artery will lead to inferior wall MI, and it will be shown on lead 2, 3 and AVF. Blockage of left anterior descending artery can lead to anterior wall MI or anterior septal wall MI, and the anterior wall MI can be seen in lead V3 and V4, whereas anterior septal wall MI can be seen on V1, V2, V3 and V4. The blockage of left anterior descending or circumflex can lead to anterior lateral wall MI, and this can be seen in V4 to V6 and lead 1 and AVL. So basically left anterior descending artery, because it's on the front of the heart, if you have seen the picture and you remember the arterial supply, so it is supplying the anterior portion of the heart. So the left anterior descending occlusion will lead to anterior wall MI, anterior septal wall MI, as well as anterior lateral wall MI. Posterior wall MI is due to occlusion of posterior descending artery, and you will see tall R waves and ST depression in V1 to V4. Another investigation which is also important is cardiac enzyme. So the unstable angina does not cause a rise in cardiac enzyme because there is no necrosis, so no enzymes will be released. However, in myocardial infarction, both STEMI and NSTEMI, there will be raise in plasma levels of cardio enzymes. So the first cardiac enzyme to rise is creatinine kinase, and it is also going to be the first enzyme to fall. It is the enzyme of choice to check for reinfarction within a few days of first cardiac event, because it starts to rise in 4 to 6 hours and peak at 12 hours and back to normal in 72 hours. The second enzyme which can be detected are troponins, troponin T and troponin I. It is the most sensitive cardiac enzyme, and it cannot distinguish reinfarction occurring several days after the first event. It starts to rise in 4 to 6 hours and back to normal within 2. So an important step in relieving pain and distress of the patient is adequate analgesia, and it is essential to relieve the pain because it will decrease adrenergic, that is sympathetic drive, which in turn reduces vascular resistance, it will reduce BP, and it will reduce infarction size, and it will also reduce the susceptibility to ventricular arrhythmias. The agents which we can use is IV opiates along with an antiemetic like IV metoclopramide, because opiates causes emesis. we should avoid intramuscular route. Why? Because the effect will be delayed due to poor skeletal muscle perfusion. So antiplatelet therapy should be started as soon as possible. We will give a single oral dose of 300 mg of aspirin within 12 hours, then followed by 75 mg aspirin indefinitely. Clopidogrel should be given 600 mg single dose within 12 hours, followed by 150 mg daily for 1 week, and then 75 mg daily. Clopidogrel plus aspirin is better than aspirin alone in reducing the risk of death, MI, and stroke. Other ADP receptor blockers can be given like ticagrelor and prasugrel. So these are given 180 mg once, followed by 90 mg twice daily. It is more rapid, that is action within 30 minutes, and more potent than clopidogrel. It is more effective than clopidogrel in reducing vascular death, MI, and stroke. There is no overall major bleeding risk compared with clopidogrel. The side effects include dyspnea, which is the most common, bleeding, rash, itching, etc. Prasugrel is mainly indicated in patients undergoing PCI for ACS, and we will give 60 mg once per orally, then 10 mg once daily. Side effects can be bleeding. Avoid in patients who are more than 75 years of age because of risk of hemorrhagic stroke. So glycoprotein 2b3A inhibitors, including tirofiban, apixaban, and aptifabetide, these agents inhibit platelet aggregation and thrombus formation. So they will decrease the risk of death and MI when added to aspirin and clopidogrel in patients especially who are undergoing PCI. So they are given as infusion 2 to 24 hours after PCI. There is no clear benefit for starting these agents prior to PCI. Anticoagulation therapy reduces the risk of thromboembolic complications like a stroke. It also reduces the progression of thrombus, reinfarction, but does not lower the mortality risk. It should be continued for 8 days or until discharge or until coronary revascularization. It is achieved using either of the following: unfractionated heparin, enoxaparin, fondaparinux, bivalirudin, etc. So treatment with unfractionated heparin requires monitoring with APTT, and it should be kept between 1.5 to 2 control, and dosage includes 60 unit kg IV bolus, then followed by 12 unit per kg per hour for 48 hours or until end of PCI. Enoxaparin is a low molecular weight heparin, and its dose is 1 mg per kg twice daily sub-Q for 2 to 8 days. Fondaparinux is factor Xa inhibitor with the best safety and efficacy profile, and bivalirudin is a direct thrombin inhibitor. Anti-anginal therapy include nitrates and calcium channel blockers, beta blockers, potassium channel blockers, etc. So I have discussed the anti-anginal therapy in details in my video part 2, which is a stable angina. So I'll describe here briefly. Nitrates decreases mortality because they dilate coronary arteries. They will reduce preload and afterload as well, and they should be given sublingually because they have extensive first pass metabolism in the liver, and so should be avoid oral dose. Contraindications include hypovolemia, symptomatic RV infarction. Anti-anginal therapy include beta blocker. Beta blockers have shown to decrease the mortality, so these all have mortality benefit. Remember, the calcium channel blocker, nitrates, beta blocker, they all are going to decrease the mortality rate in case of MI or ACS. So beta blocker should be therefore a part of long-term maintenance therapy. And the contraindications include moderate to severe heart failure, pulmonary edema, bradycardia, hypertension, severe bronchospasm. So the reperfusion therapy involves either use of percutaneous coronary intervention, which is also known as PCI or angioplasty, or thrombolysis or fibrinolysis. Reperfusion therapy is of no use and can be harmful in case of unstable angina and NSTEMI. PCI is not effective because the infarct related artery is not occluded completely. in 60 to 85% of cases. Thrombolysis is not effective because the non-occluding thrombi are platelet rich. Role of reperfusion therapy in STEMI is of prime importance in restoring the coronary artery patency. PCI is effective because the infarct related artery is completely occluded, so it needs restoration of the patency. Thrombolysis is effective because the occluding thrombi are fibrin rich. The primary percutaneous intervention is the treatment of choice for ST elevation MI. It is more effective than thrombolysis because it is associated with greater reduction in risk of death and risk of recurrent MI or stroke. It should be performed within 90 minutes of the first medical contact of the patient with MI. It gives better results when combined with glycoprotein 2b3 receptor inhibitors. And when primary PCI cannot be achieved within 2 hours of diagnosis, thrombolysis should be performed. Thrombolysis is performed in non-PCI capable hospitals and it can be administered within 12 hours of hospital presentation. However, the benefit is greatest when it is prescribed within 2 hours, ideally 30 minutes. And many sites say that it should be given within 3.5 hours. So yeah, the benefit is greatest when it is given within 3.5 hours. The most common complication is bleeding, either intracranial, and it can be performed using altiplase, streptokinase, retiplase. So altiplase is tissue plasminogen activator, which is the agent of choice. It is given as 15 mg IV bolus and 0.75 mg per kg over next 30 minutes and 0.5 mg per kg over the next 60 minutes, given over 90 minutes. Streptokinase can also be used. Altiplase is associated with better survival rates compared to streptokinase, and it is associated with higher risk of intracerebral bleeding. So you have to see the risk versus indications of thrombolysis is important. So STEMI less than 12 hours, best within first 2 hours. ECG shows any of the following: ST segment elevation of more than 1 mm into contagious limb lead or more than 2 mm into contagious chest leads or new left bundle branch block. Thrombolysis is harmful if given to patients who present after 12 hours after the onset of symptoms and the patients with normal ECG or ST depression. The contraindications to thrombolysis can be categorized as absolute or relative. The absolute contraindications include hemorrhagic stroke, ischemic stroke in preceding 3 months, CNS neoplasm, active internal bleeding or known bleeding diathesis, aortic dissection. These all are absolute contraindications for thrombolysis. The relative contraindications may include transient ischemic attack in preceding 6 months, major surgery in preceding 3 weeks, major head trauma in preceding 3 weeks, uncontrolled hypertension, that is systolic BP of more than 180 millimeter of mercury, and diastolic BP of more than 110 millimeter of mercury. Current use of oral anticoagulants, high probability of active peptic ulcer, pregnancy, these all are relative contraindications. Some important points to remember for revascularization therapy is that door to balloon time, that is PCI time, is under 90 minutes. Door to needle time, that is thrombolysis time, is under 30 minutes. Thrombolysis is beneficial only with ST elevation MI. Heparin is best for non-ST elevation MI. Glycoprotein 2b3 inhibitors are best for NSTEMI and those who undergoing PCI and stenting. So the lifestyle modifications I have already discussed in the previous videos. Medications that should be given for long-term post-ACS management is dual antiplatelet therapy. So the dual antiplatelet therapy should be given for at least 3 months. And the patients who are undergoing PCI, so those who have received bare metal stent, they should continue the antiplatelet dual therapy for at least 30 days. And for those who have received a drug eliciting stent, they should receive the dual platelet agents for at least 12 months. The beta blocker and nitrates should also be used in long-term ACS management. So irrespective of serum cholesterol concentration, all patients should receive statin therapy post ACS. The serum cholesterol should ideally be measured within 24 hours of presentation because it falls transiently within the first 3 months after MI. The therapy includes atorvastatin 80 mg daily. The target LDL is less than 100 mg per deciliter. Target HDL is more than 40 mg per deciliter, and target triglyceride level should be less than 150 mg per deciliter. AC inhibitors, which is angiotensin converting enzyme inhibitors, should be initiated within hours of hospitalization if there are no contraindication. Best mortality benefit is seen in patients with acute MI and LV systolic dysfunction, those with ejection fraction less than 35%, and it should be the part of maintenance therapy due to following advantages: because it has mortality benefit, it improves survival. So it counteracts ventricular remodeling, it prevents the onset of heart failure, and it reduces the risk of recurrent MI. Implantable cardiac defibrillator is helpful to prevent sudden cardiac death in patients with acute MI and LV systolic dysfunction with ejection fraction less than 30%. So the emergency management of ACS can be summarized as monotherapy. M for morphine, which is very important to decrease the sympathetic drive of the patient and to relieve the stress. Oxygen therapy via nasal cannula 2 to 4 liters per minute, or you can increase or decrease it as per needed. N for nitrates, which should be given sublingually. A for aspirin and clopidogrel. So these 4 are the emergency steps of ACS management. Then you can perform investigations like CBC biochemistry, including enzymes, cardiac enzymes, glucose levels, 12-lead ECG. Beta blockers can be given if there is no contraindication, and if there is availability of primary PCI, then you can perform PCI and give post PCI glycoprotein 2b3 inhibitors. Alternatively, you can do thrombolysis if there is not availability of PCI. So the complications of myocardial infarction include arrhythmia, which is the major cause of death in those who die before receiving any medical attention, and it is seen in 5 to 10% of cases, and it may be due to ventricular tachycardia or ventricular fibrillation. Second complication is bradycardia. So it may be sinus bradycardia or AV block. In case of sinus bradycardia, I have already made a video that if the patient is asymptomatic, then observation, and if the patient is symptomatic, then you will give IV atropine. And in case of AV blocks, so the usually first degree AV block and type 1 MOBITS does not require any treatment in myocardial infarction, but in case of MOBITS type 2 and third degree heart block, you will see whether it's an anterior wall MI or inferior wall MI. So in cases of anterior wall MI, they will require a prophylactic temporary pacemaker because the risk of asystole is high. However, if there is inferior wall MI, then type 2 MOBITS and third degree AV block usually are temporary and they get resolved after revascularization therapy. But if still symptoms persist, then we can always go for temporary pacemaking. The third complication is right ventricular infarction. So it is mostly seen with the inferior wall MI, and it presents with tachycardia, hypotension with clear lungs. So you will flip the ECG leads from the usual left side of the chest to the right side of the chest, and you will see ST elevation in right V4, which is the most specific finding in RV infarct. And remember, in RV infarct we do not give nitroglycerin because it worsens the cardiac filling. So how will we treat it? We will simply give high volume fluid replacement. The fourth complication is ventricular free wall rupture. So it is the most common mechanical complication following MI, and it presents as cardiac tamponade and is usually fatal. It occurs more frequently on day 3 to 7 after the onset, and treatment is pericardiocentesis, inotropes, and surgery, same as the treatment for cardiac tamponade. The fifth complication is rupture of papillary muscle, which is another mechanical complication presenting with acute mitral regurgitation, and it will have pansystolic murmur, S3 heart sound, acute pulmonary edema, and shock. So you will diagnose it with echocardiography, and treatment will be emergency mitral valve replacement. The Sixth complication is interventricular septal rupture, which is another mechanical complication that results in an acquired VSD. It will form a VSD, and it is therefore left to right shunt, presenting with pansystolic murmur radiating to the right sternal border. It is characterized by oxygen setup from right atrium to right ventricle, because oxygenated blood from left ventricle enters the right ventricle, increasing oxygen saturation. In this condition, patient present with right-sided heart failure, unlike rupture of the papillary muscle, which presents with pulmonary edema. So this is how you will going to differentiate between the rupture of papillary muscle and interventricular septal rupture. The seventh complication is pericarditis and also Dressler syndrome. So pericarditis refers to the inflammation of pericardium, and it occurs in second and third day post MI. So the patient will have chest pain, which is pleuritic and positional. It aggravates on deep inspiration and lying down, whereas it is relieved by sitting up and leaning forward. It has positive pericardial rub. The treatment will be high dose aspirin and opioids. NSAIDs steroids are contraindicated because of risk of ventricular aneurysm and myocardial rupture. Dressler syndrome is another type of pericarditis, and it is mostly post myocardial infarction syndrome, and it is pericarditis of autoimmune origin. So it occurs on 2 to 10 weeks after MI, and it presents with pericarditis, pleuritis, fever, malaise, and leukocytosis. The treatment involves high dose aspirin, which is the first line agent. NSAID and steroids are alternative options. So remember, in pericarditis, simple pericarditis, you will avoid NSAIDs and steroids because of the risk of ventricular aneurysm and myocardial rupture. However, in Dressler syndrome, which is an autoimmune pericarditis, you will give NSAIDs and steroids as an alternative option to aspirin. So that's the end of the lecture. I hope you learned something from it, and if you do, please like my video and subscribe to my YouTube channel, and you can also tell me what next topic should I make video on. And thank you.